Indeed, thank you very much, Dr. Kordi, for your kind introduction. Assalamu alaikum. Good afternoon, everybody. Thanks for coming and welcome. I will dive in directly into my talk. They just give me 10 minutes. I don't think so, I can deliver what thoughts in my brain in 10 minutes, but I will do my level best. Can we go to slides, please? Hypertension, the silent killer. Dr. Kordi highlighted clearly how we are not giving the full attention and the full prestige of this disease because it's a silent killer. It's behind every, mortality in the medical textbook. And as I will show you now immediately before we start, that this is a global cause of death. It's not only this problem. The problem that high blood pressure is projected to remain the leading risk factor in 2040s. Expect another 15, 16 years that it is a remaining leading cause of death. Imagine when you reduce the systolic blood pressure by 5 millimeter of mercury, an average reduction, relative risk reduction will be 10%. And if you double it, you will get a 20% relative risk reduction. These are data from a large randomized clinical trials. So you reduce the blood pressure, you reduce the relative risk for those patients with hypertension. Uncontrolled blood pressure. Do you know that 50% of those patients with treated with antihypertensive, they are uncontrolled? And 15% of a treated patient have also resistant hypertension. They take the medication, they are compliant to their medication, but still their systolic and diastolic blood pressure are above the recommended target by the guidelines. One more shocking point. 50% of your patients, you start the antihypertensive, by the end of the first year, they stop the medications. So drug compliance is frequent cause of resistant and difficult to control hypertension cases. Another problem, and this were found in the UK and the Czech Republic, that each increase in the number of antihypertensive medications, we know that we do have at least 5 families antihypertensive, will lead up to 85 and 77 increase in non-adherence in UK and the Czech populations respectively. What shall we do? As Dr. Kordi said, we should look for something new. We need something, we do it one time, it will help our poor patient to control their blood pressure. So we thought about the renal denervation, reviving the renal denervation. It's not something new, it's an emerging technology. It was there back in 40s and 30s, but it was really complicated. Back there, they used to do something, they call it open surgical sympathectomy for the management of those patients with malignant hypertension. And the first publication came back in 1952, till we reached now the ultrasound, passing by the radiofrequency ablations. So, radiofrequency and ultrasound. The ultrasound renal denervation, they learned a lot from the previous experiences. Before, there was a lot of variabilities when it comes to the procedure and operators. There was a lot of other problems. So what they did, they reduced these operator variabilities. They reduced the problem of focal ablations. They ablate in circumferential way. They ablate more, deeper into the vein, into the arteries. Patient resistant to hypertension, they choose patients with uncontrolled blood pressure. There in radiofrequency programs, the hypertension 3, they use those patients with resistant hypertension. And also the trial's primary endpoint, which is something very, very important. In hypertension 3, they focus into office reading. And we know, no more office readings. You should hook the ambulatory blood pressure, send your patient home for 24 hours, call him back and look for the result of your medication, of your management. So we learned a lot on the, Radiance hypertension program, which studied clearly and helped to get the approvals for the, ultrasound RDN from the hypertension 3. These many RDN position paper and consensus papers documents supported the use of RDN to lower the blood pressure, starting from 2017 till we reach 2022. Something very, very important before I proceed with my talk, to know this piece of information, that the majority of the renal nerves along the main renal arteries are within the depth of 1 to 6 millimeter. They dissected, and you can see here that they dissected the renal artery, and they looks after the the nerves supplying, the sympathetic nerves supplying the renal artery in the distal renal artery, in the middle and in the proximal, and they found that more than 80% they lie between 1 and 6 millimeter depth, and now you will know why this number is important. So we are looking for something ideal to do renal denervations, and here you are the device. We will proceed and I will show you our Paradise ultrasound renal denervation system. This is a fully automated generators with a touch screen or with a control that can do the job in a very effective, and it was uniquely designed and a very efficient way. So efficient workflow through a simple user-friendly interface, automatically detect the catheter size. You don't need to feed the catheter size, and it will adjust the energy level which will be delivered. It has a consistent energy emission irrespective of the arterial dimensions. So it achieved, why this technology is really effective, because it's achieved the primary and the secondary efficacy endpoints in 3 independent sham-controlled. So they do have a sham-controlled studies and randomized clinical trials across all the measures of blood pressure, demonstrated consistent, clinically meaningful blood pressure reduction out of at least 3 years, delivers always on treatment effect, day and night, independent patient's behavior. So in a very simple way, we do have a balloon. This balloon has a transducer inside. This is an NC balloon with a cooling system, a sterile water, which will cool when you give the heat, the thermal heating, and it has a 360-degree circumferential ultrasound energy to target the major nerves and the main renal artery. As I told you, it has a unique hydrocooling system. This hydrocooling system, it depends on water. When you start ablations, there will be no direct contact of the transducer into the wall, so less damage to the wall. Again, approximately 80 to 90% of the renal nerves are targeted with the 360-degree circumferential sonication emissions, which is the depth of the renal nerves, which I told you before. Here, we need to ablate 2 to 3, at least 2 and maximum 3 ablations per main renal artery. If you do have an accessory renal artery and the size of a 3 millimeter at least, then you can give 1 ablation into the accessory renal artery. Try to avoid ablating the ostial and very distal renal artery. We use the parenchymal shadow on the angio, and we don't put our balloon inside this shadow. We have to keep a space of 1 transducer between every ablations. We don't overlap at all, and these are the main features. Sure, when you ablate proximal, mid, and distal, we start usually with the distal. You are covering all the area of the nerve supply. This is the balloon. This balloon is an NC balloon with taper tip. It's atraumatic balloon. It's automated one. Each ablation is 7 seconds. You need to do only 2 to 3 ablations. We do have different size. We start ablating sizes, renal artery sizes from 3 up to 8. If the artery is a 3 millimeter, we choose a bigger little bit, 3.5 balloon, up to 8 millimeter. Why? It's something very, very important. Dr. Nadim will show while showing his cases that when you ablate the artery, you're supposed to have an occlusive balloon. You will give a small injection of the contrast to make sure that this contrast is not bypassing the balloon, and in this way you make sure that the balloon is really adherent to the wall. The balloon will touch. Transducer is sleeping inside the balloon in the middle. It will deliver only the thermal, or it will deliver the heat. But the balloon must be touching completely the wall to make sure that the energy will be delivered. So it preserves the endothelium when you do like that, less damage to the artery. If the transducer or like radiofrequency, before when we used to do it, we can see like there is dentations and there is a change, and this may last for a month or sometimes more. So we minimize the ablations also time and the procedure time when we use this balloon. Again, when it comes to the catheter, here you are the catheter. You can see in the golden color the transducer. And this is the balloon around the transducer. And here is the hydrocooling saline, which is not saline, it's a sterile water, normal water. Okay. When it comes to the tip, we do have an atraumatic tip. And NC balloon, you know why NC balloon, for those non-invasive. We don't want it to grow more and more when you inflate it. It just grow up to the size which is decided to it. What data, support what I told you earlier about the device and about the Paradise? There is a large program for the ultrasound, renal denervations. We do have, for example, 3 successful randomized sham controlled trials, the Radiance Hypertension Solo, the Radiance 2 Pivotal, and the Radiance Hypertension Trio. How many minutes do you have?
They're going to stop.
Oh.
Let's give another 2 minutes, please.
2 minutes will not be enough. We'll try to go fast. Okay.
We'll give additional 2 minutes, please.
Thank you. So these are the data. There's another active programs going. There is also independent studies which came. I will show you clearly and quickly about the Radiance trial, the Solo, Trio, and Radiance. Here they want to look after a change on the daytime systolic blood pressure, and they use they use the ambulatory blood pressure. They don't use the office readings. There was a significant, ambulatory blood pressure reduction with the 3 studies which looked after the resistant hypertension, mild to moderate. It was safe. There was only 1 death which was not related to the procedure. The radio sound hypertension, the study design, it's a single center, single blinded. And here they look for those patients taking 3 medications or more. One of them should be diuretics, at least 50%, achieving the maximum dose of the medication. And here they want to look for the group difference of a change in the daytime ambulatory systolic blood pressure. Radio sound also, renal denervation demonstrated significantly more ambulatory blood pressure reduction at 3 months versus the radio frequency RDN on the main renal arteries. Guidelines, or the guideline highlighted it. They give it a 2B, and they said if you fail to control the blood pressure for those patients with resistant hypertension, you may use the renal denervations. And for those patients who cannot be adherent, the American, the Europeans, the Sky, they just all of them put papers to support that. This is my last slide, and this is a just released paper like a few weeks back where they compared the radio frequency to the ultrasound, and they look after a lot of things. They found that the reduction with the radio frequency ablation is much better, the complication is less, and it is really higher than the radio frequency. Thank you very much.